out there somewhere, alone and frightened.
Rakai Health Sciences Program is a research and service program that has been in existence for over 30 years. Our field research sites are located in majorly 3 districts, including Chotera, Rakai, and Lyantonde districts, which were all part of the greater Rakai district at the inception of the Rakai Health Sciences Program. We have our field headquarters located in Kalisizo in Chotera district. But we also have administrative offices located in Kampala and Entebbe. Our major focus over the last 30 years has been understanding the HIV epidemiology and generating hypotheses for HIV control, and then testing those hypotheses in randomized controlled trials, then supporting the implementation of evidence-based interventions, and then finally evaluating the impact of those interventions. In the next few minutes, I would like to give a short presentation of the work that Rakai Health Sciences Program has done over the last 30 years. And I hope that you will find this presentation very, very useful. My talk will include a historical background to the epidemic, establishment of the Rakai Community Cohort Study, RHSP, how RHSP supported hypothesis generation and subsequent testing of interventions, the scale-up of service programs, and how this was supported by implementation sciences research, evaluation of the impact of programs through RHSP, and I will end with ongoing challenges and new research. Rakai is located in South Central Uganda in East Africa. One question we are often asked is why we chose to do our research in Rakai. Well, it was in Rakai where the first cases of Slim disease due to HIV were first identified in the early 80s, and our RHSP investigators, Dr. David Serwada and Dr. Nelson Sawankambo of Rakai College of Health Sciences, led the team which did this work. These physicians worked with Maria Weaver from Columbia University to set up the first Rakai community cohort in 1988 to assess the burden and risk factors of acquiring HIV at a community level. The first surveys showed very high prevalence and incidence of HIV, especially in the main road and secondary road trading centers. These data indicated a public health emergency, and the team embarked on testing interventions to control the epidemic. The first was a cluster randomized trial of STI treatment for HIV prevention. The intervention was mass presumptive STI treatment regardless of STI symptoms, and the end point was HIV and STI incidence. This intervention reduced prevalence of vaginal STIs and syphilis. However, it did not reduce HIV incidence at the community level. The STI cluster randomized trial results were disappointing, but this trial led to multiple additional analysis of RCCS data, which contributed to extensive hypothesis generation and subsequent intervention testing. Analysis of the effect of viral load and HIV stage of infection on risk of HIV transmission, done by Dr. Tom Quinn and Dr. Maria Weaver, are shown on these two panels of graphs. The main message here was that viral load was a major driver of HIV transmission, and that infectivity was highest in the early and late stages of HIV infection. The results were confirmed by the HPTN-052 trial, and they led to concepts of treatment as prevention, universal test and treat, and undetectable equals uninfectious, or U equals U. Another key RCCS observation was lower HIV incidence in circumcised men regardless of viral load in the HIV-positive female partner, indicating that voluntary male circumcision, or VMMC, may reduce HIV acquisition among men. The effectiveness of VMMC was later confirmed in 3 clinical trials in Rakai, Kenya, and South Africa, and these trials led WHO and UNAIDS to recommend VMMC for HIV prevention. RHSP's research and that of others led to combined HIV intervention service programs, or CHI. We also conducted implementation sciences research to support the scale-up of CHI, thus supporting translation of research into action. Services were implemented incrementally, starting with prevention of mother-to-child transmission in 2001 to provision of ART at various CD4 thresholds, which later evolved into Universal Test and Treat, or UTT. VMMC was introduced in 2007 and PrEP services in 2018. In 2016, we expanded our services from Rakai district to a regional HIV program comprised of 12 districts located in South Central Uganda. Services are supported by PEPFAR through CDC Uganda. This slide gives the entire scope of services we currently support in the region, both at the health facilities and in the communities. We give our support through 196 health facilities, where over 120,000 patients are currently receiving ART. In the region, over 300,000 men have been circumcised. Over 170,000 adolescents and young women have received DREAMS services, and over 1,800 clients are on pre-exposure prophylaxis.
The Rakai Community Cohort Study is one of the oldest population-based surveillance that has supported our understanding of the HIV epidemic. We have run this cohort for the last 30 or so years, and it has been such an amazing opportunity working with communities, working with the community leaders, and working with partners and funders and universities all over the world to see how well we can understand the HIV epidemic. So each visit starts with a sensitization session. In the sensitization, we get community leaders and opinion leaders and have them engaged, talk to each other. What are we planning to do next? And be able to also disseminate some of the results from previous visits, and also talk about what is going on globally in respect to HIV and a few other things as might be appropriate. So after the sensitization, we do community barazas, community village meetings. They can be fairly large, We hold them in the evenings. Sometimes then we do almost the same thing, but for the ordinary person in the community. Mobilize and have an engagement, talk and listen. Sometimes we do drama shows, sometimes we do video shows to mobilize communities. That happens normally a few weeks to another important activity called the census, a household enumeration activity. So before the start of a survey, each visit we do a household survey, a household census. We visit every household and try to understand who lives in the household. Who did we leave here that still lives? Who has left? Who has joined? We document birth. We document death at household level. We also document household possessions in that household, and we look at dwelling characteristics at each visit for that particular household, and a couple of other things. So that is the type of data that helps us to study socioeconomic statuses of households and mobility. We also document mobility at census. So we do a lot of interesting things at census, but at household level. After the census has been conducted, we run that data here into the data management room. It's entered expeditiously, and that piece of data supports the planning for the survey. The survey is individual, so we enroll participants 15 to 49 years. It's an open cohort, so when a child becomes 15, we enroll them. When migrants come into the household or in the community, we enroll them. And when people leave, there are procedures we do to exit that person from the community and therefore from the study. But precisely, it's 15 to 49 years, and each visit we see approximately 20,000 people. What happens at the survey is that we shall conduct a behavior survey. It's a same-sex behavior survey, and that survey is very interesting because it has different modules: the demographics, reproductive health module, the HIV, we have sex partner blocks, and then behavior and sexual prevention, sexual risk modules on condom use, on number of sexual partners, etc. And then we do linkage. The linkage means that each participant is interrogated or asked questions on their number of sexual partners, and we try to link them to their other participants whom they have had sexual engagements with. Historically, the Rakai community cohort study was house to house, even the surveys, but about 6-7 visits ago, we initiated something called a hub strategy. So the hub strategy is a very unique thing. We go to the communities and mount tents, and part of what we are doing is really to respond to public health issues. And what we have now decided is to do some modifications in the RCCS, but also be able to contribute to the understanding of what's going on with COVID-19. So this setup, as you see it, is a replica of what we do at the hub in the communities. The only difference is that now we don't have study participants here with us. Normally we have a large tent which is a waiting area, so participants are seated here. We have an administrative tent, we have quality control tents, and then we have these tents where interviews take place. Now the other administrative tents and the participant tents are not here. We are doing that from the offices. That is where the administration of this survey is going, like, you know, who are you interviewing, and etc. The supervision is in the offices, and the participants are home. But the interviewers or the field staff is here at office in these tents, and others are in different locations where it is convenient. We have started something called the telephone survey. So in the telephone survey, we are asking different questions relating to COVID. We are trying, we have identified the sample from the regular participants of the RCCS. That sample has HIV positives and HIV negative participants, and we are trying to assess issues relating to health service access during COVID, the COVID period and these lockdowns. So we want to know whether people are still able to access their HIV drugs, whether people are still able to access health facilities if they want to. We are trying to assess whether people understand COVID. Do they know the symptoms? We are also assessing whether people have had COVID-like symptoms. But what we are doing now is to telephone call them. We have come up with a criteria for identifying them using the phone. So we follow that. We have a short consent form, and then we administer that tool. So Richard here is actually conducting an interview right now, and we have so far conducted close to 4,000 interviews. Our sample is 4,000. So it is actually the real same model. He's still using the same census form to identify the participant and asking the questions and inputting them into the electronic system that we developed around May. So we have now, like I said, interviewed close to 4,000, and that sample has HIV positive people, negative people, young and older people. It only doesn't have baseline people. All those people are follow-ups. We are interviewing only persons we have interacted with in the past. But in the next 1 or 2 weeks, this activity will have ended. The local authorities, the Research Ethics Committee and the Uganda National Council for Science and Technology have reviewed our risk management plan to resume community activities. So the Rakai community cohort study, the core version, will be resuming in the next 1 or 2 weeks. So we should be able to move to the communities and conduct our surveys as usual.
The Rakai Health Sciences Program is a recently SANAS accredited laboratory. SANAS is the South African National Accreditation Services. The lab has attained that status recently, and it has a very rich menu of accreditation, including clinical chemistry, including hematology, TB diagnosis using GeneXpert, TB diagnosis using smear microscopy, CD4 enumeration using the fast caliber machine, viral load detection using the Abbott machine, and HIV and syphilis rapid testing. What you are seeing here is the accessioning part of the laboratory. This is the accessioning. However, the phlebotomy is located outside the lab as recommended in the ISO 15189, which is the standard that recommends quality laboratory practices. So upon our lab tech in the phlebotomy room receiving a request from the clinician, that lab tech ascertains the request with the patient. So if there is a match, then the lab tech goes ahead and collects relevant samples for respective tests. So when those samples are collected, samples are brought to the lab, and now this is the reception or the accessioning section of the lab. So this section basically also receives samples from the field activities, mainly from the RCCS activities. When those samples come here, they are processed in this section. We have the centrifuge, the mega centrifuge, where those samples are centrifuged to separate the plasma or serum from the cells. So after separating the plasma from the cells, that plasma is allocated into serum tubes. So those tubes are basically then put in a freezer box, and then when the box is almost is getting filled, then one of our techs enters those samples in a freezer work system. So they scan. So those tubes are allocated field levels. So they are scanned into the freezer work system. The freezer work system is the system we use to manage archival of our samples here. And then when that is done, the samples are taken to the repository. We have a repository which we commonly call here as the freezer house, where those samples are kept and stored at -80 degrees Celsius until are requested for further analysis. So this same section is being prepared to receive SARS-CoV-2 samples, COVID-19 samples. RHSP was recently approved to enhance the testing abilities, the testing capacity of the country for SARS-CoV-2. So we are currently, it is only pending procurement of test kits. It means to be the pre-amp one room. Pre-amp means pre-amplification. So pre-amplification, this was basically designed to do manual extraction of genetic material of DNA, RNA in the thermocyclers and detection thereof. So, but currently we are mainly using real-time PCR. We are no longer doing endpoint PCR. So this place is currently also being prepared for COVID-19 testing. What you're seeing here are called PIMA machines. So they are used for CD4 enumeration. I told you of fax caliber machines. So those fax caliber machines, basically we use them for research purposes. We use the PIMA machines. These are point-of-care devices for CD4 enumeration. Basically for our art clients, because they provide you results instantly, and they can be used in the field. So basically are used for CD4 enumeration for our art clients. So as you can see very many files all over, because there is a lot of documentation that takes place here. Everything that we do is documented. Everything that we have to do has to be documented first. We have very many standard operating procedures for every small, even the smallest activity that takes place here. We have a standard operating procedure for it. It's called an eye wash station. So in case you have any splash or suspect any splash, so you need to clean your eyes. So this is an eye wash station. You will see several of these on every section at every day. So that's an eye wash station. So what you see here is called a fume hood. So this fume hood is basically used to prepare reagents that basically produce fumes. Don't want stuff to any kind of fumes. So we use this fume hood to prepare those reagents that produce the fumes.
Yeah, this is the hematology section, and we do a number of tests. Among them, we do automated CBC count using our Beckman Coulter machine, but we also carry out a number of tests like the C-colin test, the ESR, the manual cell count, depending on the clinician's request. Yeah, so this is the machine we are using here. This is the ELISA section. It is a serology test, and it's a superior serology test. So here we usually do a number of assays using the ELISA, and we mostly get samples from our cohort, the RCCS, the HIV that are usually inconclusive, or the positive samples that we usually want to confirm. So our logarithm says once a sample tests on the RDT and is positive or inconclusive, we further run it on the ELISA. We use the bio-ELISA and the Mulex assay to confirm it further, so that we can totally declare somebody as positive or negative. We have our automated plate washer. These are the two plate washers we are using. And we also have our plate reader. We use the Spectramax plate reader. And we also got an incubator, a carbon dioxide free incubator we use because it's required for the assays. This is the one we use. So mainly those are the things equipments that help us to do the ELISA. We also, like I told you, we also carry out different assays on ELISA depending on the protocols, like the HSV, the CMV, depending on the protocol requirements. So we can run all assays depending on the kit supply and the protocol requests.
This is the RHSP repository. This is where we keep the samples I've been talking about that come from the different researches.
For example, when you request for a sample, we have what we call freezer work. It gives you the location of that sample. It gives you the freezer number. For example, if the freezer works is directing you to freezer 36, this is our freezer 36. You come to 36, you open it. Like you can see, our cold freezer has 5 shelves. This is 1, 2, 3, 4, 5. There are 5 shelves. And inside our shelves we have racks. We have 6 racks in a shelf. So these are the 6 racks. So when they direct you to freezer 36, they tell you a shelf number. For example, if they tell you shelf 3, you count 1, 2, 3. You go to shelf 3. Still, you find the rack, the freezer works is directing you. For example, if there is a shelf 3, rack 3, you come to this shelf 3 and then rack 3. So inside our rack, we have boxes. In a rack, we have 16 boxes. You can pull it. There are 16. So it will give you the box number. For example, if they direct you to box number 8, you count your boxes 1, 2, 3, 4, 5, 6, 7, 8. You come to your box number 8. Then you open the box. Still the box will have positions. We have from A to I, and then from 1 to 9, like this. So the freezer works is telling you that your sample is in position C3. You count A, B, C, then from there 1, 2, 3. So this will be the sample you're looking for. That's how we can manage to locate our samples in freezer works. There are so many freezers. Each freezer has a number, and it's all about identifying the number, then you find the shelf and the rack. We monitor our temperatures electronically. There is an electronic system we use. It is connected to the servers of IT people. So whenever the temperature goes down, it alerts. We receive messages on our phones and mails that the temperature of this freezer number is low or high. So these are they are called clocks, electronic clocks. They are for monitoring the temperatures electronically.
Hello, when I go to Central Uganda, after that I also clean my front, and I clean the nails, and after I clean, the rest of them is also. And after that I rinse. So our towel has 2 faces. You make sure each face is for a different hand. So I'll dry my hands. And the drying is by parting. Then this other face will be for this other hand. Still to reduce the chances of contamination. Usually there is a receiver for these towels. So whoever is going to work in theatre will have to do that. And we usually do hand washing immediately we come into theatre, so that we are able to see that all the dust that we came with is reduced. Then, in case now you're going to be within, but you realize you've been circulating through the theatre, before still you do the operation, you reinforce with alcohol to kill the germs maybe you may have surfaced within theatre. And still, even with the alcohol, we follow the same steps. Because then even this step, you make sure you open it. Because nowadays we are using disposable sets. So we open this set, but we first confirm that everything is valid. We start with the expiry date plus whatever that is inside. Now that we are practicing dorsal slit. So even this set, when we are opening it, we make sure we open it aseptically or in a way that we are avoiding contamination. So I'll open it, making sure I don't contaminate it. On this set, there is always a sticker that they request us to keep, so we also don't throw it. So when I'm opening, I make sure I follow these flaps. And this will be the last, because I don't want my hands to go through the instruments and everything that they are packed inside, because everything inside is sterile. So whenever I want to access the set, that's when now I will use a cheeto faucet to help me identify whatever that's inside and what is not required or what I should include. So this is our circumcision set. These are the gloves provided for giving anesthesia. Then these are the gloves they provide for giving for the surgery. Then these are the plastic aprons they give to carry out. It's a protective. Then this is the ordre. This is the injection, the syringe and injection for anesthesia. We have them in different sizes. One is to help you withdraw the drug. Then this other one, this other gauge is for the patient or the client. So these ones are for anesthesia. Then this is our dissecting forceps. This is used for forceps guided, so we shall keep it away from our set. So this is the strapping they provide, and this is the gauze. This is the gauze. Then these are the instruments, which includes artery forceps. We have the straight and curved. Then you'll find the sutures. It's usually very clear. 3. Then this is the wrapping gauze we put after surgery. Then we have the stitch scissor. And then this is the incision scissor. Then this is our needle holder, and these apartments will improvise as our gallipots, because we have to have an antiseptic normal saline, which will be used also to see that we kill what? Microorganisms before we start. So that is with our set.
This is one of our theaters
When the client enters our operating room, we keep on giving reassurance. We tell him what we are going to do. And what we do, we first give the anesthetic drugs. We use a mixture of bupivacaine, which is this one, and another drug called lidocaine. We mix the two in equal volumes, and we get an eutectic mixture of these local anesthetics. So we inject these drugs at the site where we are going to operate. That is around the pelvis. And after, we go ahead and do skin prepping. After the skin prepping, we do the draping of our client. Then we proceed to test for sensation. After testing for sensation, we begin now doing the incision. The procedure we are using is dorsal slit circumcision. We circumcise using a method called dorsal slit. During the trial, the circumcision method that was used was sleeve resection method. But now, after guidance from the Ministry of Health in Uganda, we are providing dorsal slit circumcision. After we have removed the foreskin, we achieve hemostasis. We ligate the bleeding vessels. And after ligature of the bleeding vessels, we close the wound. We teach them the warning sign that may necessitate immediate return to the health facility. We give them a postoperative instruction sheet that has different information. It also has an emergency telephone line that is available 24 hours. And on this emergency telephone line, the client is advised to call at any time because it is available at any time. Then we also advise these clients on how to care for the wound, how to maintain the hygiene. We also talk about sexual resumption. We tell them that they should not resume sexual intercourse until the wound is completely healed, and this one takes 6 weeks. So we also teach them other conditions that may come along as the wound is healing. For example, we give them information about tetanus infection. We teach them the warning sign that they should watch out to see if there is a problem that could be pointing towards tetanus. So we also talk about postoperative erections. We teach them how to manage the postoperative erections after circumcision. So we also give them appointment dates for follow-up. We tell them to return to the facility where the circumcision was done after 48 hours. And during this visit, the dressing is removed by the medical worker, and the wound healing is assessed and documented. And on that day, again, the client is given another appointment visit, which normally takes place on the 7th day from the date he was circumcised. And when he comes, we sit with him, interview him, and also examine the wound to see the healing process. And on that day, again on the 7th day visit, we give another appointment for another visit, that is, we call it the week 4 follow-up visit. And during this time, we are going now to assess the healing process to see whether the wound is completely healed or not. In most cases, most of the men would have healed by the 4th week, but some few go up the 6th week. So that is why we tell these men that the healing will take 6 weeks. And we teach them that it is better for them to continue avoiding HIV by practicing other prevention measures, which include abstinence, being faithful, and consistent correct condom use.
Let's be open, advise the young
For the data management team, we are required to participate in developing the data collection tools which are used in the field. We advise on the variable names, the coding of the data collection instruments. We also liaise with the quality control department to ensure that we have proper logical checks in the questionnaires. Also, because some of these tools have questions which have appeared before, we make sure that we have the same variable names maintained over time. And also we support the unique identification of the participants in those studies, because these studies generate confidential information, so we want to make sure there is a unique identification of the participants, and we also want to make sure that even if this participant or the study participant has participated in multiple studies, they use the same identifier across those studies, so that in case you want to link data between studies, you are able to do that. And also longitudinally, we have cohorts where we know that people have participated at some point and they dropped out at some other time, but they come back. So for such people, still we want to maintain the same ID that they used previously. So to be able to do that, we use what we call a linkage form in the field. They ask participants information pertaining to their previous participation in our studies. They ask more information about the members who are in the household by the time they participated in these activities, so that that information is used when searching about this person in the database. And if we find information that this is the right person, then we alert the field team to use the same identifier and make sure we maintain that identifier. After which we have a statistical team that liaises with the principal investigator, the study coordinators, to share progress reports on the studies. For security of the databases, we make sure we have password protection whoever accesses our machines. They are restricted. We make sure they are authorized to do that. Also, the systems here are supported by the National Institutes of Health, so the infrastructure, the internet infrastructure, the networking is all done by NI staff who have to ensure that they have antiviruses, and also backup. For backup purposes, we have a server on-site and off-site, so that in case the on-site server is down, the off-site server is actually used to retrieve the data.
Region Masaka region happens to have the highest HIV prevalence in the country, which is higher than the national average. So when we won this grant, Rakai Health Sciences Program was asked to ensure that a time comes when the number of people getting HIV/AIDS in the region are less than the ones who are dying from HIV/AIDS and its complications. In other words, we are supposed to work to ensure that the number of people getting HIV reduce. Now, if you look at the history of Uganda and the history of HIV, this region actually, Masaka region, is where HIV actually started from. In fact, there are some of those lakeshore places where, like Kasensero, that are known, where the first cases were documented. So this region has always had a lot of HIV. So the mechanism, it's hoped by the end of the mechanism, which is a 5-year mechanism, that the HIV prevalence, the incidence should have come down. Now the prevalence may not necessarily come down, because prevalence means the number of people with the disease. So because people are living longer on treatment, the prevalence may remain high, but the incidence should ideally come down to demonstrate that actually we are going towards HIV epidemic control. So this mechanism supports a total of 14 technical areas. Now, Rakai as an organization, when we won this grant had two themes it was operating in. The first theme is a theme of health system strengthening. Now, health system strengthening means you don't put up parallel structures. Instead, what happens is you work within the existing structures and try to make them even better. So, for example, you will have what are called, we have hospitals, we have health center 4s, we have health center 3s, we have health center 2s. So what we do as a mechanism, we are supporting all the facilities in the region, which are a total of 198. They are spread in the 12 districts, but they are in different levels. So what we do, all the services that I'm going to tell you that we are offering, we offer them working in the context of the existing structures. We don't come to set up alternative structures, we just strengthen those existing structures. So that is the first theme. The second theme is a theme of district-led programming. Now, district-led programming means you are supporting the different facilities in the different districts to offer, to do work. But the districts already, the Ministry of Health put up a leadership structure for health in the different districts. And in particular, every district is headed by someone called a district health officer. Now, this district health officer has a team he works with that is called the district health team. So what we do is, as part of supporting the work across the mechanism, we ensure that the district health leadership remains in charge. That's what they call district-led programming. The district health officer, together with his team, remain responsible for the planning of the activities, for the implementation, for the supervision, for the monitoring. Now, the others are specific services that are geared towards comprehensive HIV/AIDS care. Now, what I'm going to share with you is the program side of the work we do, because I am responsible for the program side of the work to make sure that the program work is done what happens. Some of the services we support actually start from the entry point for people in care. One, people need to know their HIV status. So we support HIV testing and counseling. So everyone who doesn't know their HIV status, we mobilize communities. We work with the communities, with the structures, to tell people, if you don't know your status and you are at risk, you get to know your status. Actually, currently we have guidelines that support what is called targeted testing. In the past, we used to test everyone, but now research has shown that you don't have to test everyone. But there are certain key populations, people at increased risk of having HIV and spreading HIV. Those are the ones actually we now look out for. So our testing is targeted. Actually, in addition to that testing, we do what is called resense testing now. So it now, if someone comes and we do an HIV test and we find that the person is positive, then now we need to know when did they get the disease? Is it recent? Is it an old infection? Is it new? Now, if we find that many people who are coming are new infections, then we want to map where are they coming from. So it could be a hotspot. Maybe there is someone there, or there are people, or there are certain practices that are increasing HIV. So if we are going to achieve HIV epidemic control, then we need to know where actually the new infections are coming from. So that is about the testing. Now, after we test, we put these people on treatment. Now, the treatment we are giving it both to the adults and the children. So there's the pediatric HIV care, there's the adult HIV care. Now, we also support HIV care in the pregnant women, which is called PMTCT or EMTCT, prevention of mother to child. But related to that, we also support children, babies that are born by these pregnant women who are HIV positive. We support the process of them to get to know whether, to identify, to diagnose, to find out whether they actually acquired HIV or not. It's called early infant diagnosis. So as we are testing, there are certain other things we do that are prevention related. For example, for men, if we find a man comes and tests and we find that the man is HIV negative, then we link them to preventive interventions like circumcision. Circumcision has been found to work, so we link them to circumcision. Now, for the young ladies, we link them to other services like DREAMS, because DREAMS is a service that was set up to reach out to vulnerable girls. You know, this region here that I talked about, the Masaka region, has been found to have a lot of young girls, adolescent young girls. And actually they were accounting for the biggest number of HIV infections. So this program called DREAMS was started up, where that is aimed at creating girls that are determined and resilient, that are empowered and AIDS-free and mentored. So what happens is, because initially what was happening is that these young girls, because some of them, their parents died, you remember there was a lot of HIV in this region, so when they would die, they become heads of families, they are vulnerable, they have not gone to school, they don't have a form of income. So some of them will get married early as a way of survival, and in that process they are abused. Some of them will engage into what is called transactional sex. Transactional sex means you don't have a dress, it's torn, so you look for a man who, if you have sex with him, he will buy you a dress. You lack food in the home, and you're the head of the home. You have men who you sleep with, and they give you money, and then you feed your family. So what the DREAMS does is supposed to help empower these girls. You empower these girls so that they don't have to go into such activities that actually increase their risks. So what we do in DREAMS, we support educational support. If it's education, we support them with means of income generation, by giving them, skilling them, basic skills like baking, so that they can do some bakery and sell, confectionaries, things like tailoring, things like hairdressing, things like soap making. So these are some of the things we skill these girls in. So that is still part of the program.
I've been in this program for the last 30 years, working in different capacities, and I was the director of the program for the last 12 years until 2017, overseeing very many different activities of the program. In 2017, we structured the program, and the intention was to make sure we create a new department that can be able to take care of our grants in terms of funding, then science, as well as catering for the students who are staff, as well as students coming from outside the Rakai Health Sciences Program, from outside the country, as well as national students. So the department we created is the Department of Grants, Science and Training, which I now head. Our training aspects covers both international and national students coming from different universities, as well as staff whom we support to upgrade. As you heard from this presentation from different departments, the Rakai Health Sciences Program over the years has really made a lot of milestones in terms of research and programs, and it is a resource, a very big resource that is helping the whole world to understand the HIV epidemic, and to be able to help set up interventions to try and control the HIV epidemic. And this resource is very critical and important for researchers in the whole world, for fellows, for students, and the other people that are interested to learn from the data we've collected that you've heard about, the samples that you've heard about when we went to the lab. And we welcome students from all over the country and all over the world to come and be able to utilize the resource that we have for training. That out of it you will be able to learn lots of things, and it will motivate you to pick out very interesting lessons and also develop your career to go forward. Thank you.